Okay. Hello, everybody. Good afternoon. Welcome to one of the immunizations webinars in our series hosted by the Illinois chapter of the American Academy of Pediatrics. My name is Alexandra Arca, and I am an immunizations manager here at ICAP. Thank you so much for being here today. And we are going to have Dr. Anita Lee to present this year's HPV Trends and Updates webinar. Please note that our session is being recorded today. This recording and the slides will be posted on our website later. You can go ahead and use the Q&A feature to submit any questions that you may have during the presentation, and we are going to answer them at the end of this webinar. Next slide, please. And here is our continuing medical education accreditation statement. To receive CME, you will need to fill out the evaluation that will be sent to the attendees later today. Even if you are not seeking CME, we do encourage you to complete an evaluation and let us know how we did today. Next, please. And here is our financial disclosure grid. All disclosures have been mitigated. Next slide. All right, and then with that, I want to introduce our speaker for today. Dr. Nita Lee is an associate professor of obstetrics and gynecology at the University of Chicago. She specializes in the diagnosis and treatment of women gynecologic malignancies. Her focus is on providing comprehensive care to women diagnosed with ovarian, uterine, cervical, vulvar, or vaginal cancers. Dr. Lee's research interests includes cancer survivorship, cancer disparities, and clinical trials focusing on new therapies for ovarian, uterine, and cervical cancers. She is an active member of the Gynecologic Oncology Group, or GOG, a cooperative research group supported by the National Cancer Institute. And with that, we're going to switch over so that Dr. Lee can share her slides. And we are very excited to have you today. Thank you so much for joining us, Dr. Lee.
Thank you so much. Thanks for everyone being here. I'm going to go ahead and share screen and the usual function of making sure that everyone can see the right version of everything. Let's see. Are you able to see my slideshow now that let's see if I can put this on. Is the view okay?
Yes, we have the title page up right
Okay,
now.
excellent. Good. Just want to make sure. No matter how many things we do, we always have to check. So thank you very much again for the opportunity to talk to everyone in this group and to have this be a potential resource for people to think about for HPV vaccine. So I'm just going to be talking through HPV vaccination, some trends and updates. Some of you will obviously be very well familiar with this, but I think from the perspective, I think this is a really important space that as an oncology provider and primary care providers that we really link up in terms of like what we're doing for prevention. This I think we've seen already. So to go through our learning objectives, to understand the burden, trends, and disparities in HPV-related diseases and cancers, review the current data on HPV vaccine uptake efforts in Illinois and nationally, some indications, gaps, opportunities, and best practices for HPV vaccinations, as well as some of the really exciting data that's been coming out on the effects of how effective HPV vaccine has now shown to be in precancer and cancer. So understanding the burden trends and kind of going over what this is. This is sort of like the why of we're here. Why are we all attending this webinar? Why do I feel very passionate and get excited when I get asked to talk about this topic is that this is a topic that really hits home to me personally as an oncologist because of the amount of patients that I still see who are diagnosed with cervical cancer every week. So every week I have 2 or 3 new patients who get diagnosed with a cancer, which I think is otherwise preventable. So there's over 37,000 cases at the US of HPV related cancers in each year that can be potentially prevented. And 80% of everyone who's ever been sexually active will have HPV. And so that's a really important idea that this is like a really common infection and something that we can actually mitigate. There's a lot of morbidity and long-term sequela of the treatments of cancer or even of precancer. And so this idea of like how this vaccine helps, it's not just cancer prevention, but it's also cancer, it's cancer prevention, but also kind of thinking about all of the downstream effects of those things. There's obviously deaths due to HPV cancers and male and female patients, so all of us are at risk. So I think of pediatrics and primary care and primary prevention of HPV and diseases and cancers as such a critical partnership because HPV vaccine is really our only method for primary prevention. And we talk about some other ways that HPV can be transmitted, and we'll talk a little bit about that. But in terms of like a true primary prevention, this is the upstream ability of us to like operate at a public health level. And so for me as an oncologist, for every like, if I'm just seeing people who are already diagnosed, we're sort of like way far behind, and that's really what prompts me to kind of see how we can partner. Secondary prevention relates to kind of what we do in gynecology and afterwards, which is the surgical treatment of precancerous lesions. But there's many diseases that don't have a screening, and we'll talk a little bit about that. So HPV, as you know, a human papillomavirus, there's more than 200 types of HPV, and most HPV can be very harmless and goes away by itself. But then, as we know, many HPV can lead to genital warts or other types of cancer. The two types that are kind of targeted often are 6 and 11, which are kind of more of like the condyloma or the HPV-related genital warts. And 16 and 18 are really some of the high-risk types that lead to the majority of cancer cases. And it's the persistence of high-risk types in the tissue that leads eventually to cancer. So it's the most common type of like sexually transmitted infection, but it really does have like a high prevalence in the population in general, and that most infections will be cleared in 2 years. So how is HPV transmitted? So it can be transmitted to skin contact. So that's really important because it may not be through like traditional sexual activity with penetration. HPV types that are specific to genital areas can be transmitted to skin, as well as, considered a sexually transmitted disease, but you sort of have mixed feelings about this because I think some of the stigma associated with HPV vaccine and HPV related diseases is this idea that it's all sexually related, but it's just so common that we want to make sure that people understand that we need to kind of think about this and the fact that we have a vaccine to target this. And again, extremely common compared to even other infections. And unlike other infections, which can be treated with an antibiotic and then just resolve, HPV, similar to like other vaccines, when you think about your varicella vaccine, you think about shingles in older people, this is actually something that's going to potentially be lay dormant and be in the system and in those cells for a very long time. So when we think about cancers that are attributable to HPV in the US, and this is not even thinking about worldwide where HPV related to cervical cancer is the most common, we look at the distribution here, we often really are talking about sort of like the HPV related to cervical cancer. And that's what usually comes up, like this is a women's problem, or this is a problem of like, of just cervical cancer. But when you look at this distribution and you see the difference between male and female, we see that many other HPV attributable cancers are happening. And when you look at oropharyngeal cancer, which we'll talk a little bit about, we see that the rates of male patients getting oropharyngeal cancer are actually higher in the US than cervical cancer, which is again really kind of as we start to think back to like targeting HPV vaccine for boys and girls, this becomes really important in terms of cancer prevention. So head and neck cancers HPV is thought to cause about 60 to 70% of oropharyngeal cancers in the United States. Obviously, other cofactors that we remember from, our time in medical school and things like that is like when we think about head and neck cancers, we often think about cofactors of smoking or alcohol use. And that was kind of like the traditional model for head and neck cancers. But we really have seen this really rise in HPV related cancers, and that's actually increased the number of these cancers altogether. Male over female, there's no current screening test available. And these often, because they often present and start in the back of the throat or in the tonsillar area, they often present in late stage until somebody feels a lump in their throat or an enlarged lymph node. So there's a significant amount of morbidity related to the treatment of this. And this is kind of getting at to the background of the why that we want to have the HPV vaccine be such an important part. So when we think about HPV head and neck cancer treatment, I'm obviously not an expert in this area, but like looking through this and reading through patient stories, we really think about like how we think about chemoradiation, which can be very toxic at times, surgery, which can be very disfiguring, immunotherapy, which has its own other side effects. All of these treatments have a lot of sequela. And so we think about the patients who are affected, their cancer diagnosis, and what this does to them in long term is not just like, okay, you have this cancer and you're cured, but not only the the deaths, but due to the like ongoing pain, issues with swallowing, eating, speech problems, neuropathy due to chemotherapy, hearing loss, long-term dental issues and tooth loss, psychosocial stressors. So all of these things kind of like play in to thinking about where we can intervene upstream again. So I found this to be really interesting. This was a assessment of oral papillomavirus prevalence in a sort of like a clinic population. So this was like them actually taking saliva specimens and looking over time. They happen to have like this cohort that they've studied since 2011 and looking over time to see just the prevalence of oral high risk HPV over time has increased really dramatically in the both pediatric population, but really highly in the adult population, right? And so this trend is kind of indicating to us that like there's a signal going on that like we really need to be thinking about how to target this because this incidence is not stopping and is actually becoming sort of a kind of like a, like the herd immunity. It's the opposite. We're getting a lot of spread within different populations as well. So when we look at oropharyngeal and anal cancers among men and women, again, HPV related, we look to see that in total, these are still lower rates, but you see that there's a really big discrepancy in oropharyngeal cancers in men related to HPV. And this is important to kind of think about just like our overall statistics of what we can change. I'm going to jump a bit to cervical cancer and dive in a little bit more since that's my area of expertise. But I think the same idea can kind of globally respond to some of these factors are really the same cofactors for anal, vulvar, vaginal cancers. And the big issue with all of those other cancers and head and neck cancers that unlike cervical cancer, we don't have a way to screen for them. So with cervix cancer, we know that anyone with cervix is a risk. It's the fourth most common cancer globally worldwide. Most women are diagnosed between, average age being 50, but there's a lot of women who are in their reproductive ages under 50. Most women are at risk if they've not had a PAP or had not had a PAP in 5 years. And again, this is like a precancer that can be caught and treated very early, but that still does involve surgery and some different other types of potentially morbid situations. When we look at sort of racial discrepancies in terms of like race and ethnicity, we look to see that in terms of incidence, we see sort of somewhat similar incidence in certain communities, but we see that like among Black, Hispanic, and American Indian, Alaska Native populations, we see a higher incidence rate and a higher mortality rate, particularly among Black women and among women who are in American Indian, Alaska Native communities or identify as that. And obviously there are multiple reasons for this. A lot of it has to do with some of the structural issues related to screening and follow-up, but I think it's important to think about these things. This is just more of a backup in terms of like incidence rates and what we're seeing. Again, kind of seeing differences, particularly among Hispanic, American Indian, and Alaska Native, and mortality rates similarly. I put this in here to just kind of think about like setting the stage for talking about sort of HPV vaccine. And I guess we could have put it in a little bit later when we're looking at trends. But when we look at vaccine coverage in terms of adolescents age 13 to 17 being up to date, we see that kind of Illinois is sort of somewhere in the middle, right? We're not like the best, we're not the worst, but we're kind of in the middle. And some of this really depends. And I have some data later looking at like more different groups within Illinois, for example. But in general, states here like Iowa, North Dakota seem to be doing particularly well. Some of these states actually have school mandates for their vaccine. So that's something else that can kind of obviously improve the vaccine uptake. This is just sort of showing that HPV to cancer is, that trend. This is an example of cervical, but this is really the same thing for anywhere HPV is attacking, is that this slow progression from persistent high-risk HPV infection to cancer can sometimes take years. But if it really, sometimes we don't see it in a year's phenomenon. We see sort of like the end of that tail. And so we see people who are coming in and they don't realize that their first abnormal PAP was not that long ago, right? Risk factors include smoking, immune system, HIV, and transplant as well to kind of accelerate the fact that your body's immune system is not able to clear this. And again, the primary prevention really kind of holds true in this like normal population, right? So our vaccine opportunities are well before anybody is exposed to this. So why don't we just screen and not even worry about HPV vaccine? I think the issue is really there's a problem with screening. Not everybody gets screened. An older data slide suggested that 7 out of 10 women who were not screened actually had a regular doctor and had health insurance. So we can imagine what the issues are when we have a climate of like not having as much insurance, not having enough ways to tackle this. Now in Illinois, we're very lucky. We have the Illinois Cervical Breast program, which actually is CDC funded and allows us to actually screen underscreened and uninsured women for breast and cervical cancer to help alleviate some of this. But this also requires a lot of follow-up. There's also the issue of time, discomfort with exams, lack of knowledge that this applies to people, lack of navigation, fear, shame, embarrassment with pelvic exams, and a history of prior abuse or trauma. All of this background, I think, with cervical cancer also has really colored how people have taken on HPV vaccine. And what we've been trying to do is to say, like, let's separate out the stigma and the shame related to all of these things to kind of just make this as more of like an acceptable vaccine of just cancer prevention in general as well. Again, our eradication of cervical cancer goals really have a lot to do with primary HPV vaccine, and then obviously increased screening and the early detection and diagnostics. Obviously, that's, it is all a trajectory and sort of like a continuum, but I can't emphasize enough how important the HPV vaccine will be. So the WHO has a strategy to kind of eliminate cervical cancer, and it really is this. Their strategy is a little different. Obviously, each country, based on their resources, will do this, but prevention through vaccination, screening, and timely treatment, right? So their goal is to say we really should get 90% of girls fully vaccinated by HPV vaccine by age 15. Now that's different than some of our like US goals because of the fact that we vaccinate boys and girls very importantly because of what cancers we are seeing in the US as well. So again, we know screening saves lives, but there's people who don't get screened. So people get missed, they're uninsured, they're disabled, immigrant communities, rural communities. We just know that these things are like vaccines, screening alone is not going to do the trick. So our goal vaccine timeline is actually thinking about this. And so this is where we're putting things in perspective of like, this HPV and like that HPV was actually the cause of this was really not discovered until almost like the 1980s. And when we're thinking about the first Gardasil vaccine, which came out in 2006, we have our strategies that are WHO development, Gardasil 9, which is now the only vaccine that is available and protects against 9 HPV types, is launched. And this is really kind of our target is to kind of eliminate these different types of things over time. And a lot of this depends on like, what is our uptake in country? I'm going to skip over that a little bit. So there are some, just like basic screening guidelines. I don't think I need to go over these as well since this topic is mostly on HPV vaccine, but in general, we're starting at age 21 and going until 65. So what's sort of our current data and understanding on HPV vaccine and uptake? So when you look at like 2015 to 2022, when you look at age HPV vaccine initiation among adolescents by insurance status, you can kind of see that the uninsured are actually, falling behind in terms of who's getting this. And then many of the other insurance, Medicaid, other insurance, private insurance as well, and the US overall fall in this like 70% range. And that's initiation and not necessarily completion. I think it's important to kind of think about like who are the uninsured? Are we missing them with vaccine for children? Like what are opportunities? In the 2023 study, 60% or so of adolescents in the United States had received all recommended doses of the HPV vaccine. The percentage of eligible adolescents who are up to date was 10% lower compared to those like born in 2010 compared to those born in 27. So that data suggests that like we're not actually catching as many people as the age has increased. So that definitely is of a concern. Statewide vaccination rates are sort of for Illinois, 69% completely up to date, 81% have had at least one dose. And when we look at this compared to the US, it's, we're pretty close to the US value in terms of where we are, percentage of those adolescents. I shout out to St. Jude's Research Hospital. They have a strong HPV cancer prevention program, and they've created some state profiles for all of us to use, which I think are really wonderful. When we look at 2023, the US overall, having received more than one, is 77. Illinois is at 81%. US overall, again, so we're actually doing pretty well, but it still falls below our 2030 goal of 80%. So here's some data by like looking at different like race, ethnicity, insurance coverage as well, and sort of thinking about like who is up to date. So we look at the green lines and we think about who's up to date, and that's I think really important in terms of like up to date. We know that that's like falls below in terms of just receiving one dose, and so the groups that really show up as potentially areas that we need to be targeting is patients who are in our rural counties and boys versus girls, the uninsured population. I mean, I think there's growth opportunity for all of us in all of our institutions, but I think we can kind of think about how does each person's location may need to have different strategies for that as well. So I think this is important data to kind of like sort of see how we can kind of think about like what's happening in our individual locations. Illinois does not necessarily do county by county HPV vaccine because there's a lot of limitations in what the Illinois Department of Public Health can kind of capture, and it limits in like the public health system of like being able to capture all of those, and it's not necessarily the same element of required reporting as the other vaccines, which is a big policy issue. So to review the indications and recommendations a little bit for this, this is a prophylactic HPV vaccine. It's a DNA-free virus-like protein. It sort of has major capsid antigens, and these serve as the immunogen to induce a strong humoral response that creates antibodies. Normal HPV infection does not create these antibodies, and so that's really important because we can get this HPV infection, but our body doesn't actually create circulating antibodies that are meaningful. So again, this is a non-infectious, it's non-oncogenic, so it's not a live vaccine in any way. So the HPV virus, there's a small element of this coding region that is created and introduced into this to be able to create this like external viral like particle, and that's what basically is what we kind of use to be able to stimulate the immune system. So I think that that's basically a way that it doesn't it's not viral, it's not infectious, but it helps us to be able to create the right immune response. So I think that, the response to HPV is different than the one that relates from HPV infection. So in terms of like the natural infection, you may get some kind of like local immediate, but like your seroconversion is very low and it's very low titers. So they're delayed. And because of that, in contrast to when you get vaccinated, studies have shown a very high conversion rate in the serum as for all HPV types, including the vaccine, with a lot of cross protection of different HPV types that were not included. And so that is what gives the vaccine kind of its more long-term effect. So I think, we know a lot about efficacy of HPV vaccine as more and more time has gone by. So Australia was the first country to implement a national HPV vaccine in 2007. And so we have some really great data from there. And other European countries have also reached like a 10-year post-vaccine program implementation period. And so that's important to kind of think about this because it is really hard because there's like a long time frame for when HPV infection, when vaccine is happening, and when we would see the cancer that we still have to kind of think through. And other countries that have sort of implemented like sort of gender neutral vaccination include like Austria, Croatia, Germany, Italy, Norway, Sweden, Switzerland, UK. Many countries in Africa are doing girl specific to be cost effective, but there are a lot of moves towards general vaccination of both boys and girls. So I think this is sort of an interesting data to look at like post-vaccination and prevalence and how even among unvaccinated, the prevalence sort of declined in some of these populations because of the herd effect in terms of how different people were being able to like get. So pre-vaccination, the whole era, for example, if you look at HPV 16, 21%. the population prevalence. And then when you look at the post-vaccine prevalence here in these three columns, obviously in those vaccinated was very low, but you also see a benefit in the unvaccinated as the herd immunity is actually having an effect. So again, there's also been findings of substantial decrease in genital condylomas, decrease in HPV prevalence among heterosexual men, and there's been several mathematical models published about reduction of other HPV-associated cancers, and now some newer data that I'll share about this. So our current guidelines are HPV vaccine guidelines that are starting at age 9, ideally 9 to 10 or 11 to 12, and then up until 15, you can basically give 2 doses. And then if you're doing after 15, you have to give 3 doses. So in the first dose series, I think the benefit of doing it before you're 15, you only get to have 2 doses. It's actually available and FDA approved for up until age 26. And at age 27 to 45, you can consider that you can actually continue to that series. And so I think that's important to know that this is actually currently indicated for 9 to 45 for prevention of cervix, vulvar, vaginal, anal, oropharyngeal, and other head and neck cancers, as well as dysplastic lesions. And for males, it's also recommended for these cancers. And so to get the indication, they've had to show that these precursor lesions and these cancers have actually declined. So any licensed HPV vaccine can be given. There's no maximal interval. There's no need to repeat the dose if the schedule is interrupted. There are minimal intervals here in terms of 4 weeks between the first and second dose, 12 weeks between the second and third dose if you're doing a 3-dose regimen. The extended intervals between first and second dose have also shown to be effective. So if it's missed in a cycle or with a pediatric annual exam schedule, you can still give it. The dosing for age 27 to 45, we're supposed to consider those that most likely to benefit and think about shared decision making. So thinking about adults who may be at new risk, immunocompromised, changes in lifetime circumstances. There's not a clinical antibody test to see if you're immune. The issue comes up sometimes in the 27 to 45-year-old categories that many people do not know if they were vaccinated as a child. And so that's also another issue that I think we need to think about. So I think that, there are some newer data that's suggesting that maybe a single dose schedule referred to as an alternative off-label single use can provide durability. We just don't know yet. And I think the issue is, sorry about that. We want to see if the US will follow suit and change that. Excuse me. Sorry about that. Okay. So in looking through our next sort of issue, we have our issue of safety. So the most common adverse events are injection site and mild low-grade temperature. This is well tracked and monitored. There's over 350 million doses worldwide that have been given. So I think it's really important to be able to share that information in terms of how safe it is to give. There are certain contraindications and precautions in terms of anaphylaxis, allergies, immediate hypersensitivity to yeast, moderate or severe acute injury is very rare. And minor acute illness is not a reason to defer vaccination. So if you're very sick, obviously we're going to defer. But if you really have some minor colds, we probably would still give the vaccine on that day. So looking at some of the data on the effects of HPV vaccine on precancer and cancer. So early vaccination is key. So population-based cancer registry data from multiple countries supports the importance of early vaccination. So especially substantial reductions in the risk of cervical cancer. And I think that's where we've really started the conversation about looking at the value of starting the HPV vaccine conversations at age 9. So there's a lot more opportunity to potentially decrease how many shots are given per visit as the age of vaccination increases, especially as you get to the later teen years, is probably slightly less effective, but still really important. I think the other issue is that it offers a more time for completion of the series by age 13 or 14. So there is a push towards this. Obviously, as a group of pediatricians, I will defer to you as to how you're going to be able to kind of put some of these things into practice. When we think about HPV vaccination, we know for some of the data, even the early data back in 2020, 2008 and 2016, we saw significant declines in number of rates of precancer lesions. And that was really important in terms of a precursor lesion to what we were seeing. And so that's a sort of an important way when we look at like kind of this age group of like what we were seeing in 2028 and then versus what we're seeing in 2016. The duration of protection against high-grade cervical, vaginal, and vulvar neoplasia is observed to at least 10 years after vaccination, and ongoing studies have shown persistent antibody levels, and additional data will be continued to be updated. There is no current evidence that a booster or revaccination is necessary. So a cross-section SEER study demonstrated that we were looking at sort of like cervical cancer incidence in young US females after HPV introduction. And this showed that there was an annual incidence rate that decreased. It's difficult because this is also a rate of cancer that's fairly low because most people are not 15 to 24 when they're getting this cancer. But at the same time, I think it's important that we kind of think about setting up these studies and thinking about sort of the long-term data. This was a study that was published in the New England Journal of Medicine that really showed the highest rate, and this was a study that was done in Australia looking at over 1.6 million people who were vaccinated versus unvaccinated. And among the vaccinated group, 83% initiated the vaccine before age 17. There were 19 cases of cervical cancer in the vaccinated cases. And really, these were fairly low, especially if they were vaccinated before the age of 17. So when you look at this data, it's pretty striking in terms of the number of how high the rates were of cervical cancer here in the orange line of the unvaccinated group versus the vaccinated between 17 and 30 years, which is the dotted blue line, and then you look at the vaccinated at a young age. So the incident rate ratio was over 50%. The other covariates and everything else that they looked at, you really saw the differential between the age of vaccination. So through this, we could conclude that the risk of cervical cancer in those vaccinated before age 17 was 88% lower than those who were never vaccinated. And that's a really important number in terms of adjusting and seeing how important the impact for the younger age of vaccine was. Now, this is another study looking at in Sweden, looking at HPV vaccine reduction in cervical cancer by 63%, and this was especially effective again for the younger girls. A newer abstract that was presented looked at a very large cohort of close to 3 million people to look to see the effects of HPV vaccination on the development of HPV-related cancers, and really looked back to see how did men and women do. So in these, when we were looking at HPV vaccinated patients, we saw that males vaccinated for HPV were at decreased odds for HPV-related cancers, in particular head and neck cancers, and females vaccinated for HPV had lower odds ratios for both HPV-related cancers and cervical cancers. And so this really is the first sort of like start of these data. And again, it's a little bit skewed because it's a younger age population, but I think that we're going to still see this benefit as we get older and older studies go by. So I think a lot of the data that's now maturing really tells us that this primary prevention is working, and we've let the time go by to really see that benefit. I wanted to kind of switch a little bit to talk through some of these like myths and facts about HPV vaccine, which I think are important in terms of as we think about how we're counseling patients and what type of tactics that we're going through. This was a really nice table that was created by the ESCO, which is a European Society for GYN Oncology, which talks about myths and fake messages about HPV vaccine and thinking about answers and how to kind of target this, right? So one myth is like pap smears are also effective. You don't need to vaccine. I think we've covered that. We can only screen for cervix cancer. We can't screen for anything else. And there's 5 other cancers that affect both men and women. Screening is secondary and primary prevention is the way that we want to kind of emphasize things. The idea that HPV vaccines are so new that there's no data on it and they're just so untrustworthy, right? And so this idea that like we really do need to instill into our patients and our and to our parents that we have a lot of experience, that there's now 25 years of experience with these vaccines. There's 15 years of like real life experience with other beyond kind of the trial data, right? And the side effects have been well documented internationally, and vaccine safety has been confirmed by many authorities. There was a myth and kind of like misinformation floating around about HPV vaccine can causing ovarian failure or infertility. And there's no connection between HPV vaccine delivery, ovarian failure, and following observation of over 1 million females. Of note, they didn't add this in here, but I think I added this to this table as well, is that HPV infection treatment for cancer or precancer can actually lead to infertility. So this is also something to think about because I have patients who come in to see me with their parents and the patients are in their 20s, are coming with their mother and they're like, what could I have done? Right. And this is something that like they're really nervous about how my treatment recommendations are going to affect their fertility, but we've sort of missed that window for actual prevention. And so I think thinking about this in a more global way for parents is another opportunity. That vaccines can cause autoimmune disease, neurologic disease, and death, and the incidence of this is the same in HPV unvaccinated and vaccinated populations. Again, back to the stigma, myth number 5, that children are not sexually active, so there's no need to vaccinate them. We know that the earlier you vaccinate, the better the immune response, and fewer doses are needed when individuals are vaccinated under the age of 15. Again, the strength of the prevention. A big myth is boys and men do not need cervical cancer, so why would we bother to give them a vaccine if it's not going to help them? And the truth is that like we really see that it's not just like the importance of sort of community vaccination and men and boys spreading HPV to females who will get cervical cancer, which was the old sort of modeling of this, was that we know that oral pharyngeal cancer and other HPV cancers are actually affecting just as, if not more men than women. And this idea that gender neutral vaccination provides sort of the best protection for all of us. So I think the other myths and facts about HPV vaccine is sort of this idea that like after the first sexual intercourse, it doesn't even matter. Maybe it won't even matter anymore that we have to do this. But in clinical trials, most young women who had been sexually active still had a high level of protection, even in those circumstances, and that there is efficacy data up to the age of 45. There's also newer data that even after treatment for HPV-related disease, that the vaccine can potentially reduce the risk of subsequent disease. And that's some of the data from cervical cancer treatment and pre-cancer treatment. One of the myths that we went over a little bit is this idea of like natural HPV infection, and can this actually create a protective antibody? So why would we even need to do this, right? This is a lot of like different talks about like vaccine hesitancy is like, it's better to just get the disease and then your body's immune system will do this for you. But HPV is pretty tricky in that it evades sort of the normal immune response in some ways. And I think we know that the antibody response in HPV vaccine is a stronger response and gives more robust protection. And finally, HPV vaccine increases sexual behavior, promiscuity, or that discussing HPV is implying that you think that their child is going to become somebody who's promiscuous. The truth of the matter is that like anybody, we want to be able to target this much sooner than any age of initiation, and that there's no evidence that HPV vaccination increases sexual activity. And studies suggest that there is not earlier onset of sexual activity among those getting HPV vaccines. So when we think about sort of like limitations to HPV vaccine, there's sort of the perception, there's incomplete protection potential. We really want to make sure that people know that even if you've gotten a vaccine, you still need your cervical cancer screening, the vaccine cost, and low provider recommendations still become is one of the major issues that we have to kind of think about and think about how do we sort of like think about our own biases, our own attitudes as well. There's some really important considerations that I think are true regarding reimbursements for vaccines and how, a practice can kind of keep their vaccine rates up. And I think that's obviously there are many probably experts on this webinar that can discuss that along the series. But I do think importance of like thinking about the long-term public health ramifications of the cancer vaccine is pretty important. So I think a couple of like key areas of opportunities to think about would be sort of opportunities for vaccinating childhood cancer survivors. There's a higher burden of disease of HPV related diseases and cancer, and there's much lower rates of vaccine. So I think that's an important opportunity in terms of screening as childhood cancer survivors are getting back into normal pediatrics worlds as well, in terms of making sure we're thinking about HPV vaccine upkeep. We're often thinking about sort of like engaging communities and tailoring the message. So you know your community and your practice best, like who are going to be your lay leaders that you want to engage. Immigrant education and community outreach is important, language and literacy choices. But I really think about this sort of like key person, like who's the person even in your own office that can really drive that messaging. And I thinking about sort of like the buy-in that's like very consistent. Things that can provoke doubt in patients are sort of like, low grade fevers, mild illness, like the clinical team providing different recommendations and not giving a strong and clear recommendation. So when thinking about ensuring vaccination, sometimes we think about sort of like the bundle for recommendation and can we bundle HPV vaccine with the other childhood vaccines that are given at the same age group? And the question becomes, is that not starting at age 9 an opportunity to not to have parents feel like all these vaccines are being given on the same date? There's the communication pattern of sort of presumptive communication, which assumes people are ready to vaccinate and saying sort of like, we're going to be doing vaccines today, as opposed to sort of participatory conversation style, where we sort of say like, did you want to get this vaccine? How do you feel about this vaccine? And it's not that we don't want to give patients and parents a chance to discuss, but I do think there is something about the messaging to make sure that it's consistent and using all of these different opportunities to be able to kind of answer questions and to sort of like promote this vaccination across the office. The presumptive approach seems a little bit like, some people don't feel comfortable with that, but I think in terms of like efficacy of like the higher uptake of what we actually see, we definitely see that both in observational studies and in randomized controlled trials when people have tried different communication strategies. And I think that's really important to kind of think about normalization and allowing people to understand that we really think for the long-term health, this is going to be something that we can bring in. So, so I think in summary, like HPV vaccine, we think of this as safe, effective, durable. It can provide long-lasting effects, and recent evidence for cervical cancer, head and neck cancer, and dysplasia data continues to mature. Vaccination rates are improving in Illinois, but they're still not at goal. And really thinking through how we think of the climate right now for vaccine uptake, hesitancy, our responsibility as public health officials and physicians to kind of think about how do we bring sort of like data and scientific communication to be able to sort of best help our patients. So I'm very interested to know what the group thinks about all of those things in terms of like what we need to do next. There's a lot of different other resources, including the HPV Roundtable, American Cancer Society, Mission HPV Cancer Free, CDC.gov still has all of their data and all of their information on file. So I think that's good. I think that, our goal again is to reach 80% by, originally it was by 2026, and I'm not sure we're going to be there by 2026, but I think as we keep that goal in mind, I think we can think about, elements of that we can do to help our patients and our children. I want to thank you everybody for your time. This is our group at U of C. I would love to kind of take any questions. I'll stop sharing, and our group and myself are very much available for more detailed discussions with your teams, trainings. We have a lot of like different trainings for different members of the team that would potentially be in a clinical office or any type of department. So we're very excited to be able to share any of those things and strategize with you about HPV vaccine. All right. Thank you.
Thank you, Dr. Lee. That was such a great presentation. While we're getting this new slide pulled up again, we do have time for questions. So if anybody has any questions, oh, we do have somebody raising their hand. How do I do this? Dr. Chandrapuri, you can go ahead and unmute if you wanted to say something.
Can you hear me?
Yes.
Yeah.
So thank you so much, Dr. Lee. That was really fantastic. The question that I have for you, you mentioned that there are some states that actually do require HPV vaccine for school. It looks to me like that might just
Rhode
be
Island, I
Rhode
believe.
Island and Virginia, I think.
Yeah.
Um, anything you know about how that was implemented or sort of passed through uh, their Congress, their House and Senate or whatever to create that, or was it just? I'm just, you know.
Yeah, I mean, this was definitely at the state level. I think it's an interesting thing because we've like talked quite a bit at length of like, should we do it in Illinois, right? So anytime we think about like HPV policy, we will always bring that up as like, should the gold standard or something be that we want an HPV mandated vaccine, right? I think that what has happened, at least like from my perspective, is that there's been a lot of concern about potential pushback when those types of measures have been brought up in the state legislation. So where we've been able to get kind of things on, like we were able to pass a pilot several years ago on being able to IBCCP sites being able to elect to do HPV vaccines, right, at the places where we're doing cervical cancer screening and other things. But the issue of the pushback of I would say, people who were like, did not believe in vaccines became that people were almost like a little fearful of introducing it as a state mandate to like raise. And so this was something that happened, I think, interestingly enough, in Texas, I believe, there was a very short-lived mandate that went into effect when
Right.
the vaccine first came in
Early
place.
on. Right, early on.
Super early on. And then there was like this huge pushback and then it got like totally dead. And so I think people have been so hesitant that I wonder if it's paralyzed us a little bit, if that makes sense. But I think that when you start to talk to some of the lobbyists and some of the people in the state legislature, they're often playing a fine game of trying to get just enough votes to get all of that through and trying to like take into consideration like how each state legislature will vote based on like the county they're from. So I do think it's still a really good goal. I don't know like how to tackle that because I feel like even people who have the best intentions are very fearful of that because of backlash potential. Does that make sense? It's like the irony of it, right? We're like,
yeah. No, that's why I was
so
asking if there was something very specific to those two states that allowed it to pass
I
through.
don't know. Like that's a great question. I will have to like I'll dig into that to see like how did they do it, right? Like
Thank you. And if any, I'm sorry, they were saying the same
questions or
thing.
comments? I just want to kind of hear from people as to see like what are you seeing in practice and like what would be more helpful for the pediatrics groups or the primary care physicians, because from a clinical perspective, like I'm really seeing the tail end of this, right? Like I feel like we're really so passionate about this because we just see like just the suffering of people who are getting these cancers. And I feel that if it wasn't for the stigma of HPV and it being sort of sexually the connotations, if somebody was like, there's a breast cancer vaccine, like people would be lined up for this. Right. And so we just have like an uphill battle there. And I would love to hear from what people think.
We do have a question here that says, I work with a early Head Start program as a health specialist.
Oh,
Would you
that's so
feel that
interesting.
it would have a benefit to start talking to parents about the HPV vaccine this early? Or should I tailor the conversations towards the parents, especially since a lot of my cases are immigrant or migrant families?
I think this is a great question. I think that it's never wrong, but I know that each of us who are working in public health fields, such as health, I mean, there's so many topics to cover, right? So, like, how do you best decide what to cover when? But I think if you're talking about like vaccines in general, and maybe for immigrant communities, introducing the idea of like the vaccine schedule to parents who may be coming from a country that didn't have the same schedule, or maybe they're trying to get their kids back on track, this is a way to kind of introduce the fact that, like, we also have this cancer vaccine that's being used in a lot of countries around the world to protect children, right? So I think it would depend on the context of like how you felt comfortable with it. We are actually kind of modeling some of our vaccine uh, efforts in the postpartum period too. So that's sort of interesting for us, like because we have opportunities to potentially vaccinate young mothers who are under 26, but also provide like education at the same time because they're sort of in a childhood education space, if that makes sense, or like learning about things for their kids. And some of them have older kids. So I think that's a great question. I think it's trying to figure out where and knowing your audience as to where they think it would have the most relevance.
Okay, any other questions or comments that anybody wants to put into the Q&A?
We're a small enough group that I feel like I'm like, what do you guys think? What are you doing in your practices?
I think another point to this person's question was if you feel that there would be a benefit to start talking to parents about the HPV this early. This is from the person that was working, for a Head Start. And I wanted to know, like, do you have an opinion as to how early is too early, anything like that?
I think it's all contextual. Like, I think it just depends. Like, if you're sort of like talking about vaccine in general, you could just mention it, right? Like, it's always a time to normalize it as like part of like the thing that we should be doing. So it's more, so it could even be like, the time that you introduce it, like, oh, you're a new pediatric visit. Like, these are the things that you can anticipate for the next several years, right? So it's always great to be like, oh, your child's 8. Of note, these are going to be the series of vaccines they're going to get next year because now you're only coming once a year, right? So I don't think there's ever a time. I feel like we talk about HPV vaccine, like I'll talk about it with some of my patients who are clearly over the age of being able to be vaccinated. But to think about that influence point, like, we often have our patients who have experienced cervical cancer really be some of the biggest advocates for their own family members, like children and grandchildren, for getting HPV vaccine, right? So we'll often mention that as part of their like, survivorship element is like, because many people will be like, what could I have done or what can I do? And we often will tell family members like, hey, there is something that we can do. And so we use those points of introduction. So I think there's not really like a right or wrong age.
Thank you. I think that's such a great point too about especially like just normalizing the conversation, like constantly
Yeah.
bringing it up. I think that's great advice. Thank you so much for that.
And I think that's something we can do in our like social spheres as well. Like, right? Like we operate in like different places, like we are our jobs and our public health and our medical jobs, but like it's surprising how many people, like I was shocked when I had this like random conversation with a bunch of moms where like all of the moms of sons were like, wow, like my pediatrician, like fairly suburban practice, like never told us that we should get HPV vaccines, right? I think I gave a talk with a pathologist once and he came up to me afterwards and was like, my pediatrician never told my son to get vaccinated. Now he's 16. And I'm like, wow, like that happens, right? Because we don't know as well. So I think anytime we can talk about it, it's pretty important.
Thank you.
The other
Um,
thing I would say is one other thing is that I do think like in a practice, like in a clinical practice, I think it's really important to kind of think about how we can kind of really engage all of our staff members. So like whether it's the staff who's doing the counseling or the check-in or the MA or the nurses, because I think if there's discrepancies in how people respond or react to like encouragement about the HPV vaccine, that can make a huge uptake, right? So I can go in and be like, I think you should take this HPV vaccine, but if like my nurse, who my patient may trust more, says, yeah, you could take it if you want, like that messaging really can kind of like skew things, or vice versa, right? The nurse says something, but then the doctor doesn't follow it up by putting in the order right, or, saying, discounting that or something like that. Then I think that like consistency of messaging is super important too.
Absolutely. Thank you so much, Dr. Lee. You've been such a great resource. This was a great presentation. Since there are no more questions, I will move on to the next slide, Annalise. And we just want to encourage all of you to check out some of our social media toolkits. These are available on our website. We have them on the respiratory virus page, the VFC page, and the school resources web pages. These toolkits have downloadable images and some pre-written captions that you can use to upload and to share them on your own social media pages. You can also go ahead and write your own captions if you feel so inspired to do so, but those are there to help you along the way. The toolkit is such a great way to add to your social media pages and to share some quick and helpful information. Especially right now during respiratory virus season, we do have a great toolkit available for that as well. Next slide, please. And lastly, we do encourage you to check out some of our upcoming events. Registration for our CDPH and IDPH VFC trainings, which are ongoing from March to September. We have them at various locations. They are available for registration now. We also have some more immunizations webinars coming up. We do have one in a month, exactly 1 month, March 19th. It's about the history of vaccines, lessons learned, and a look back in time for Adolescent Immunizations Week. And then we have one in April, immunizations webinar, Back to Basics, a roadmap for vaccine advocacy and policy. We would love to see you there. You can scan the QR code or type in that website that you see there to register. And with that, thank you so much all for being with us today. I think this was a great presentation. I hope you enjoyed it. We will be following up with the slides, the recording, and the evaluation for continuing education credits later. So thank you, and we hope to see you soon. Bye.